So there are 5 key messages that the NAEPP guidelines, updated in 2007, emphasize that everyone who is educating about asthma touch on at every contact. The major 3 are basic facts about asthma, the roles of medications, differences between controller, medication and quick relievers, and patient skills. And just to reinforce those, the basic facts about asthma, including going over what the airways of a person looks like who has asthma and a person who does not have asthma, and the role of inflammation, and then what happens to the airways during an asthma attack. For the role of medications, that includes understanding the difference between long-term control medications and quick relief medications. And then patient skills, taking medications correctly, identifying and avoiding environmental exposures, self-monitoring, recognizing early signs and symptoms, and then using a written asthma action plan to address those early warning signs, adjusting your medication in response to the signs of worsening asthma, and then seeking medical care as appropriate. Most of these were reviewed in the segment 1 that Dr. Harkins and Dr. Hunsinger reviewed on clinical aspects of asthma and long-term management. They reviewed the assessment and severity key point, the key second one of appropriate asthma management, using these medications, and adjusting medication. PACE, Physician Asthma Care Education, expands on those key messages a little bit using the guidelines implementation panel priorities. So they talk about what happens in an asthma attack, again, how medications work, responding to changes, how to take medications, but they also add in talking about safety of medicines, the goals of therapy, criteria of successful treatment, managing asthma at school, identifying triggers, and referring to further education. The PACE program, since it was designed for clinicians, presents a guide for addressing all this content in 3 visits, saying that it doesn't take a lot of extra time and it can be done in 3 visits. And visit 1, they suggest what happens to the airways in an asthma attack, how medications work, responding to changes in severity, and how to take medicines. And they suggest that in visit 2, you talk about safety of medications, the goals of therapy, and the criteria for successful treatment. And that visit 3, you concentrate more on environmental triggers, managing asthma at school, and referral to additional asthma education, and then again reviewing goals of therapy. As I work with many of the clinics on this project and with several asthma educators that we've worked with, and listening to Dr. Harkins, I understand that sometimes you don't get 3 visits. Patients may come for the first visit, as we've found, and may not come again, so it's many providers feel they need to address all the messages at every visit. Also, with the chronic care model, which is part of this project, we're looking at health system redesign, trying to include allied professionals in addressing asthma education, and looking at the model of the pre-visit, the visit, and the post-visit. And that's partly because there are studies now showing that when a patient leaves a provider, 50% of the time they don't remember or didn't understand what the provider said. And so in addition, dividing it into that pre-visit, visit, and post-visit allows for an allied healthcare person to review what the provider said, check for understanding. So I've added an additional slide in here which I would like all of you to provide feedback on. And that's dividing the content up into this pre-visit, visit, and post-visit. And I've integrated what I've learned from La Familia and the Gibson Clinic. So if you and Dr. Harkins and the providers will all take a look at that and let me know what you think about this slide. So I put in the pre-visit, the asthma control test. I know that at Albuquerque ABQ Health Partners, for example, they are integrating the asthma control test into an online tool so that a patient could fill it in even before they come to the clinic. And then when they come into the clinic, for example, Julie was sharing with me that she'll review what has triggered an asthma attack before she even takes the patient back to the provider. And I'm suggesting maybe that you might want to also review what happens in an asthma attack and how the medications work. In the provider visit, then the provider would review the asthma control test, and I've heard Dr. Harkins say she will do that because there's often points that she needs to clarify, and it's a catalyst for promoting conversation with the provider. And then safety of medicines, goals of therapy, the criteria of treatment, reviewing medication, adjusting for changes in asthma control, identifying triggers, and maybe touching on managing the asthma at school. Then in the post-visit, the nurse or MA might clarify what the provider reviewed by reviewing the goals of therapy and seeing what the patient understood. And maybe this is the appropriate place for a demonstration and return demonstration of inhaler device and the use of a spacer, review of the asthma action plan, and helping with a referral if the provider has suggested a referral for additional education. Or also maybe this is the place where an MA or a nurse could help make sure the asthma action plan gets to the appropriate places, and then a review of goals of the therapy to see if the patient understood. So I would like to use this as a point of discussion and ask the providers what they think about this distribution of the content.
Well, I think for our clinic, I'm lucky because I get a respiratory therapist that does the pre-provider visit for the most part, asthma control test, talks about asthma attack, reviews techniques, and goes through a little mini curriculum. And then I spend time with them reviewing their control test and going over, I really want you to be able to do everything you want to do, not have any missed school days or work days. And this is the goal of how good your asthma could be. Answer their questions, which they don't ever really have. And then if I get the sense that they're not, maybe it's a little too much for them, I sometimes will have our respiratory therapist come back after I've already done this and review peak flow meter logs. Again, make sure they really get their question. Or if I'm starting a new medicine, because I've changed my mind, then they come back in the post-visit to really kind of review all of that stuff. But again, I'm lucky that I have a respiratory therapist that can do that. But I think that, having during the checkout process would be great to have someone give, make sure they have their action plan. Are there any questions? Because then they will come back and, help clarify it before the patient actually leaves. And you're right, they may, if they're sick, they're going to come back to you. But if they feel like they got it, they probably won't. So trying to hit all the highlights, I think, is a good way to kind of divide up the tasks. So I like that division. And I do try to follow this kind of bit, but I have the respiratory therapist that goes pre and post. What about in peds?
In peds depends on where we are having the first visit, because most of the time we see the patients in the hospital. So when we do the consult, we have our first session. So the attending would see the patient, make the recommendation, and then one of our nurses or one of the respiratory therapists goes in their room and does the education at some point before patient is discharged. So they have a luxury of taking their time, spend as much time as they need because patient is still in the hospital. Mm-hmm. And they do the education at that visit, and then we see the patient back within 3 to 4 weeks for the follow-up visit. And then here's our second chance to go over more details to make sure they understood everything when they were in the hospital, make sure they are using their inhalers correctly, and pretty much every time they come back, we review
Everything.
not everything, but we make sure they understand. If there is a question about asthma control, we definitely check their inhaler techniques to make sure they're doing it right. We ask them about how often they use it, and if everything is right, great. That would be just quick checkup rather than doing further education. And if this is the first, if we see them in the clinic first time, our RT also does the asthma control test. But other than that, they don't obtain any more information. And then the physician goes in, they do the evaluation, and then one of us, either the nurse or me, we go in and we do the education. And then we get them the prescription, and again we go over the techniques one more time, because one of the most important things is actually how to use the medication. And if they come back, we check with them how much they learned the first time, and we go over whatever needs to be covered in more details. We do get actually questions about safety of medications, and they always have questions about height and the side effect and steroid in kids. So we actually spend a lot of time answering questions about the side effects of the drugs.
Michael, do you have anything you want to contribute or have any thoughts?
Yeah, I'd like to. First thing that we don't do a post-visit. That just really doesn't happen here, and I'm wondering if we need to have more asthma educators on board, or have our nurses become certified asthma educators. I think that would be helpful. And the other thing I see in this plan is I don't see where the pulmonary function test happen.
Did we lose
Yeah.
you?
But ours, it's in the pre-visit or
Yes.
post if I'm not sure if I want that. But right, I have to, like I said, the luxury of having it all right there. But I guess it could be either.
Either one?
But if the pre-visit, then you've got all that data before you actually see them and kind of get an idea of what's going on with them.
It's like we actually fell off.
Everybody?
It's right in.
Julie, are you still there? We lost everybody?
Okay.
Did we lose them or did they lose us?
It's showing that we're disconnected, but this is not disconnected. So let me just
Excuse our
get
technical
us
difficulties.
back here.
Julie's doing spirometry, so I wanted to ask her where.
You know, because this work is all in the and we're really looking at delivery system redesign. So how are you going to leverage what you already have to get it done and not stress out about it? And how can we help you do that?
Hello, is anybody on the line?
Yeah, he has one.
Wow, we don't usually fall down like this.
Yikes. It's a bad one to happen on communication.
Yeah. Especially if like they're adding their 2 cents and like, whoop, we don't care.
Yeah.
We are the experts. Could they be quiet out in the hall?
Yeah.
I know. What are they doing out
Do you want me to ask?
there? Yeah, let 'em shush.
Does anybody have a cell phone? Could you call and ask him to try again?
Let's do that. Let's do that.
Because I think Michael would really like to offer more. I did thought about spirometry. I saw that. I thought I missed that one. I didn't put that in. It wasn't a key message on the face thing. So
And another thing that we do, Kathy, is actually pathophysiology of asthma. We actually use our models that we have.
Oh, that's what I usually meant by what happens with
Okay.
asthma.
But yeah, we talk about those models. They work like a charm. When they see it, the difference, it works great.
Yeah, I think so too. We've tried to give a lot of them out to. They're using them. I've gotten some feedback. Oh, I saw this school nurse had this
Cute.
up in Las Vegas when I went up last week. They said that.
Cool.
It made a difference.
Yes, I think we did.
Hello, is anybody still on the line? Yes, we're having some problems. It looks like I do have a few people still on and people trying to get back on. Let's try, if you would, I apologize for the problem and I'm not sure what it is yet, but if we could use a different number this one time, let's try that. So anybody who's still there, let's dial in using 1-866-260-9272. And that again is 866-260-9272. I'm going to try to connect us. Oh, wait. Hang on one second, please. Hello? Oh, Sean, we're back. Okay, let's go ahead and use that number. Anyone who's still on the line. Go ahead and call back in using that new number. Sorry about that.
I like that he's actually here.
What's that?
Oh, I said I like that he's here and actually takes care of it.
Yes, yes, because this has happened at Echo before.
And you have to
Oh yeah,
find
it's the
somebody.
audio
And I had
provider.
sometimes I had to try to figure it out.
Find somebody to come.
And I used to have Kevin doing it.
Number's not even in there.
Because we had 3 clinics going on. Ones that would come over or...
Yeah.
And now I'm like, wow, Kevin's here and we have all these problems. We didn't know how to solve them before. We didn't even know we had problems.
And I know how it feels, Kevin.
And the pressure. Everybody looks to him. What's happening?
Dial 9581.
Welcome to the meeting one.
It's not right. Okay. Let's do this the old-fashioned way.
You have reached a non-working number at the University of New Mexico Health Science Center. For further assistance, dial 272-2111.
Take a breath, Kevin. It's all good.
We're okay.
Take a breath.
We're
all
okay.
good.
I didn't reach a number at UNM. I didn't press 9, probably. Okay, let's do that. Sorry.
Welcome to the Meeting One conferencing service. If you're the host, please.
Bossa Nova.
Your conference room. You are the host. Access is immediate. For a menu of available prompts, press the star key, 6, and the pound key.
Celia, Dolores Trujillo, and Julie McDaniel.
This is Michael. I don't think the university's on.
We are
We are
on.
now.
Okay.
Sorry. You had brought up a good point about where to put the spirometry. So we do it at our pre-visit, pre-provider, I guess, visit, for the most part. Unless I decide not to do it that time, obviously if they're sick or, in exacerbation. And sometimes if I'm not sure and the patient says, oh, I'm great, and I find on exam, sometimes I'll do it kind of in that provider part and then come back and review it with them. But good point that we didn't really put that in. It wasn't included in the PACE as like a big component because at the time it was developed, I think this was prior to the big push for everybody to have office spirometry. I may be making that up, but
I think you're right. No, I think you're right because it was 2006.
yeah, and then
The
that
guidelines
was
2007. So, Michael, do you do spirometry beforehand?
You haven't given me a spirometry yet.
Oh yes, I'm
bad, Kathy.
That's
Bad.
coming from me. That's right.
There's no,
That was good.
Yes, that was a good one. Julie, do you do spirometry before the provider visit?
It just depends. If they discover that there's a breathing problem, then we'll do the spirometry to decide what the problem is. If it's already a known asthmatic, we just do it as maintenance.
Mm-hmm.
But it could be, like if they're a new patient, it would be pre-provider.
Mm-hmm.
If they're established, then we just do it just as maintenance.
And do you have any comments about the splitting up of this content in pre, post, and provider visit?
No, I like your film here is exactly how we handle it.
Okay.
I like it.
Okay. So this section of PACE is addressing communication strategies. And I wanted to just preface this with that the communication section and the whole PACE program really is based on a social cognitive learning theory, and one of the principles in particular called self-regulation. And so they've designed a survey for providers to take, and the principle or the idea behind this strategy is that it's most effective to learn when you're self-evaluating. So you're self-observing and reacting to your own observations. So in the handouts that went with this program, there was a one-page survey on communication strategies. And so I wanted you to know that ahead. So as we talk about these strategies, then you can think about which ones you already use, because you may use many of these already. If there are new ones that you'd like to try out and observe yourself and comment, that's in the handouts. And there are two key points of this section, and the first one is that good communication helps with adherence and makes patient teaching more effective and promotes self-confidence. And the background for the communication strategies is that excellence in medical treatment is worthless if the patient doesn't take the medication. Compliance is closely linked to clinician communication and patient education. And most clinicians, when they're surveyed, believe they are good communicators, but ironically, when you survey patients, they feel that clinician communication and education is not adequate. This kind of underlines the challenge we're facing with adherence, so that many times when you survey patients, they will report that they're adherent, but when you do studies, those same patients are actually taking their medication less than half the time. And the implications for that is that clinicians, as Dr. Harkins said before in the first segment, can't predict better than chance which of those patients will be compliant, which will be in that 50%. And so we have to educate all patients well. And the aim of the following slides will be to provide a theoretical framework, a way to think about that clinician-patient communication, and to demonstrate strategies that you can improve. And these strategies have shown to be effective, actually. So the first theoretical framework is what we call the health belief model. And I'm going to ask Carol to chime in on these because there are some similarities with motivational interviewing. These beliefs that clients have influence their willingness to follow the treatment regimen. The first one is that I am susceptible to this health problem. And the second, that the threat is serious. The benefits of the recommended action outweigh the cost. And that they're confident that I can carry out, or they can carry out the recommended actions. One that maybe is from motivational interviewing that Carol said we should consider for all of us because it is a challenge to get patients to adhere. And seriousness maybe also contribute to the importance that a patient has. So not only how confident they are, and we can say, how confident are you on a scale of 1 to 10?
0 to 10.
Thank you. But if it's not important to them,
Right.
that's a challenge that we face, and it's hard to
overcome.
Yeah.
And for the provider to understand, to ask a question to let you know how important it is, so that you can discover that about your patient. Because I think a lot of times we think this is really serious and you have to do something about it. But in their mind, what's more important is that a teenager has acne, or they're thinking about the birth control pill, and really asthma's nowhere on their radar. And a way to bring the provider and the patient together is to talk about the importance and the confidence, link them together of getting through this asthma management plan.
Okay, and so when I go through these communication strategies, I'll ask for Carol to give us more examples of how we can do that. So beliefs about susceptibility. Some families will resist accepting the diagnosis because they may have experience with someone in their family being crippled by asthma. And so if they accept this diagnosis, it might mean that their child would be so crippled, so they would deny the diagnosis and therefore not follow the treatment plan. And also, some people may feel that asthma is a psychological thing, caused or made up by the child, and so they might resist the diagnosis. Beliefs about seriousness. If the family thinks asthma is not serious, they are less likely to follow the treatment plan. But if the family overestimates the seriousness of asthma, they may also not follow the plan. So this may enter into a discussion about when do you bring up how serious asthma is? How do you say, you could die from asthma? So beliefs about the benefits and costs. The benefits of therapy may be obvious to us as clinicians, but may not be very clear to the patients. Again, this may be importance.
Mm-hmm.
And the perceived costs of therapy would include financial burden of care, fear that the medicines will harm the child, and we'll talk a little bit more about that. And the regimen might be seen as time-consuming and hard to carry out, and so they may feel like the costs outweigh the benefits. Do you have anything you want to add there?
Yes, thank you. There's a strategy in motivational interviewing called looking forward. And this is particularly helpful, I think, with adolescents, is to say, asthma is a serious disease. And if we can't figure out how to better manage this together, you and I, what and we don't make a change, what do you imagine could happen? And let them really go through what they imagine a serious asthma attack looks like, or that their life becomes really restricted because they can't, in their minds exercise, or try to get a picture of what they imagine it would look like if they don't do something about it. And then you can help fill in the gaps where the picture's not clear or they are maybe misinformed. And that's an opportunity to really talk about seriousness, where the patient perhaps won't feel that you weren't listening, that they're being talked down to. Because I asked you first, what do you imagine it would look like in the future if you didn't make a change? So then I can come in with some information and maybe reframe their perceptions about that.
And you're providing them an autonomous role to
Yes.
to say that. So you're not, I need to tell you.
Right. And I think really with adolescents, it's so important to have them look forward, because they don't generally on their own, right? They're very in the moment
They're
creatures.
invincible.
Yes. So let's project out into the future what this would look like. And there's an opportunity to close some information or knowledge gaps.
Excellent.
I think that also applies to some parents too. We had a study that as part of that we would do a pulmonary consult, just a one-time pulmonary consult, and I saw a kid, a 12-year-old, with FEV1 of 40%, and dad had passed away at the age of 35 due to asthma attack.
Oh.
And mom was telling me that they don't use the medication regularly because they cannot afford it, and she's not going to use the saving for the college to use to buy asthma medications.
Perfect opportunity.
And to me, it's like, your child is not going to make it to college at this rate.
Right. There's
So
your
we
opportunity.
had to have, a serious talk about how she should spend the money right now to get the medication and to use it appropriately as it is recommended, or there may not be any future for college.
How did you approach that issue of the risk of?
So after that first visit, I scheduled them to come back to the clinic so we can actually spend more time and talk about this and get the social workers' help if there's any other way they can actually take the medication. But I had to sit down with them and talk about the risk factors that this child has to have severe asthma attacks. It was very difficult, and mom got very emotional, but there was no other way
Right.
to do it. It was one of those times that you had to tell them that your child is gonna die.
Did you
Before
do that
making it to
by
college.
sharing statistics about? Or how did you do that?
Just some data on risk of dying from asthma. Pretty much that was the case.
Did you use that graph with the no? What,
No.
Just
No, this is like 4 or 5 years ago, but no, just presented some data and how things can happen. We gave examples of a couple of patients that we had lost because they had an attack right away and they were not doing everything right. And I think that just, and again, the dad who passed away at the age of 35,
From asthma.
that was like, this is the biggest risk factor. Same thing can happen. And I think sometimes emphasizing on genetic helps a lot.
why do you think that is? Why genetic?
Because they have seen
It's
it in their
real to
family and they
them,
know
I
it is
guess.
real and it can happen to them.
Not that thing over
It's
there.
not
There's no-
like
they cannot
4,000. I
disregard
won't
it.
be one of the 4,000 that die of asthma, because that's a group out there that has no relation to me.
Right.
Probably.
Right.
You have the genes.
Yeah.
Okay. So it helps if you have that if you have the evidence of that family history.
Yeah.
Thanks for. Did anybody else on the line want to contribute any experiences that they've had? I'm waiting 10 seconds. Okay. So the next slide here actually comes from a study. And this study was done by one of the authors of the PACE program, Noreen Clark, I think her name is, and from University of Michigan. And it was a study she did with Columbia University in a big hospital in New York City. And they had interviewers go into the emergency room and interview 445 parents and children who were there for an asthma attack. And there, I have that study if anybody wants it. There's a lot of things they learned from that study, and these are 3 of the things they learned from that study. That 39% of those families believed that medicines were addictive. 36% believed that medicines were not safe to take over a long period. And 58% believed that if they used the medicine regularly, that it would lose its effectiveness.
That's a lot.
So these are some of the fears about asthma medications. And when we talk about strategies, we'll talk about ways to ask questions that draw out these kinds of fears, underlying fears. Beliefs about the ability to carry out the recommendation. Research shows that when you're confident you can do something successfully, you do it more often, and you are more persistent in the face of difficulty. Having said that, I will say that the study showed that those families who were less confident did not have more ER visits. And I shared that with Carol, that I don't know if that means that that families are not very good about understanding what that confidence means. That maybe it's not related to how competent they are with their knowledge.
Well, we were talking about maybe it was really important to some of those families to stay on track. That I may be overwhelmed by this discharge paper that you got me and all these meds I'm on, but it's so important to me to take good care of my kiddo. I'm going to get it done so I have fewer ED visits. You know,
So
I don't know, I'm just guessing.
Hypothesizing.
Yeah.
But that was, I think, a surprising result that hypothesis did not really pan out in this particular study that they did. The implications of these barriers to communication and the theoretical frameworks that we're talking about means that the clinician needs to work hard to establish open communication that permits these beliefs to be discussed. The barriers to that, of course, to effective communications are, the number one is time. So clinician doesn't have very much time, as you all know. And so the patient recognizes that, senses that, and they feel maybe that they're wasting the clinician's time. So they may omit details, they may not share things, they may be embarrassed to share things, they don't understand medical terms, and that may create a barrier to communication between them and the clinician. And if there's not a lot of time, they might not feel like the clinician actually had time to listen to them, and so probably doesn't really understand their problem, and so their therapeutic prescription may not be valid because the clinician didn't have really time to listen to them. So some strategies to help us cross those barriers. The first 3 here are really strategies to address the patient's anxiety level. We understand again that half the patients leaving say they didn't understand what the provider said. So these are strategies to help address that anxiety, to reduce their anxiety so they actually can listen to the message that you're going to present. And there is a DVD that goes with this course, and so I'm going to present some of the examples of these strategies, and some of you may have examples that you'd like to share. So walking all the way into the room as opposed to just coming in and standing and presenting your message, smiling, maybe not wearing a lab coat that separates you from them, establishing eye contact if it's culturally appropriate, and I recognize that in New Mexico it's not always culturally appropriate to establish eye contact, so you'll have to understand when that might not be appropriate, or think about that. But positioning yourself close to the patient at eye level, leaning slightly forward in to show that you're listening, and these strategies are called closing the social distance. I've heard Dr. Harkins say that cell phone use sometimes is a barrier, and she will mention when she comes into the room that she's turning her cell phone off, and so why doesn't you go ahead and turn your cell phone off, and then we can get
Pay attention to each other.
pay attention to each other and have a significant conversation and then move on. And I've heard some providers say that they post signs on the door saying no texting allowed, turn off your cell phones. These are new barriers that have come up since the PACE curriculum came out. Another one I've heard is that sometimes there's furniture in the room between you and the patient that kind of creates a barrier, and it's good to remove that, and that helps close the distance and make people more relaxed so they can listen. Use of touch. And I know a new one that's probably impacting this listening relationship now is that we're using electronic medical records. So all the clinics that I'm working with now have electronic medical records, and so they're entering things in on the computer, maybe in the exam room, and maybe that creates a barrier. And maybe you can ask all of you about that if you think that creates a barrier and how you address that.
I don't enter anything on the computer. I'm old-fashioned. I'm old. So I sit looking at them. I write down on a piece of paper what they're telling me, and then I'll deal with my dictations and other entry stuff after they've left.
We do the same thing.
Okay.
We just write on the log sheet whatever information we're asking and we need to make a note of, but we don't enter any information in the computer in the room.
But if you do, it'd probably be a good idea to actually face the patient or put the computer where you're actually looking at them instead of your back being to them. You know, if that's what people do. I'm old.
Any thoughts from anybody online about nonverbal attentiveness that you want to contribute?
I do use the computer in the room because I can't keep up without it, and whether it's asthma or anything else, I like to show the parent, like the pulmonary function test if I was doing them, or the growth chart, or what I'm entering, and I think that involves them. It certainly takes some effort to make eye contact and not turn your back while you're entering in the computer, and I don't do that. I face them. So I find it helpful, though slower.
But then you're in the computer era, you're engaging them to look and see what it is you're doing.
Yeah, I find that they're interested that way. Anyway, that's my personal experience.
That's great.
Thanks, Michael. Anybody else?
Amelia too.
La Familia?
Yeah, we face the patient and turn the screen towards the patient, and they can watch as you're typing and correct your spelling.
Yeah,
Cool.
I know my physician does that too.
And we also make eye contact.
Yeah.
Thank you for sharing. Another strategy here for reassuring the patient is to see right away what their immediate concern is. So, for example, if they're doing a follow-up visit from being at the emergency room and they're wondering if they have asthma, saying right away, even if you do have asthma, we have good therapies now and can use medications to control your symptoms, and say that right up front before you move on. That's one a reassuring message, and I don't know, Dr. Harkins, if you have some that you use right away before you start.
No, I think those are the ones. I'm just thinking about the patient that I saw Tuesday that has asthma, but she also had this interesting little, what I thought was a lymph node. And so I sent her to have it biopsied. And the main reason she was very anxious about the results, plus she was having an asthma problem. But, it was like, okay, it's not cancer. That was like her first, she was, okay, thank God. Now can we talk about why I can't breathe? You know what I mean? But figuring out what it is that is their main issue is key, because then they'll actually listen to the rest of the stuff potentially, and you can address the other issue. But that was her. You could just tell she was just like,
She wanted to talk about that.
right. She was barely breathing, but she didn't really care about that part. She wanted to know what this biopsy was. So.
That's the negotiating the talk. You
Okay.
know, negotiating the what are we going to talk about right now, so that particularly when a provider, because I hear this a lot in the ComTC, I do the motivational interviewing around the pediatric overweight and obesity, and this need that providers have to tell it straight. This is not good for you. You have to make a change. And I hear that, you know, it's my job. I've been trained to do this. I can't just let them talk about their acne or, you know, whatever it is. And what you were just speaking to, Michelle, is negotiating that talk. This was the thing on her neck was the most important thing to her in that minute. And if you took care of that, and then we're going to talk about asthma, everything goes, because this need was addressed. So it's called negotiating the talk.
Okay.
I think that's a very, very good point, and there's something on our EHR that I just found, and the line says main concern. And it's the child with abdominal pain, but they're really concerned about an appendicitis. Or it's the child that has asthma, but they're really concerned about the lymph gland. And once you hit the main concern, and I put that down in the chart, they know that you're listening. I do think very much that the rest of the visit goes well.
Yes. Thanks.
Thank you.
So one more thing, in pediatric
Yes.
patients, usually mom comes in the clinic with 2 other kids. And sometimes, I'm sure Michelle doesn't have to deal with that.
I do.
You do. But usually what we do, we take someone else in the room with us to keep the kids busy while we're talking to mom. Because constantly mom is trying to see what the other kids are doing, what are they touching, you know, who's
remember
crying, get the bottle. So we take someone else in the room to keep the kids busy while we're talking to mom, at least for 5-10 minutes, so she can stay focused.
Anybody want to add anything else before I go on to the next one? Okay. The next one is these 2 strategies are to try to help improve the exchange of ideas and feelings, so that you can gather the information that you need for diagnosis and treatment decisions. And the first one is called interactive conversation. And we all probably know this as the open-ended questions that encourage dialogue. And I included some examples that I took from the motivational interviewing text. And in fact, this is on page 46 and 47, and they have examples that are from an asthma patient. So I remember I even had it marked. So some of these questions are, how can I be most helpful to you today? Or, what exactly happens when you have an asthma episode? So questions that they can't say yes or no. Tell me more about your asthma. So those are interactive conversation questions, and it allows you maybe to then put the client in the driver's seat. So you're not saying, do you have asthma symptoms today, but you're saying, what are your asthma symptoms today? Some way that puts them, so they're driving it, and then you can collect information that way. Does that make sense?
So you're getting their perspective of the whole episode, what it looks like for them, what it means to them.
But you're less in the directive mode. The next one is eliciting underlying fears. And this is the one I think is very important in asthma because, as you said, they have a lot of fears about medication or misconceptions, maybe also included in that. And some ideas I had for open-ended questions that might bring some of those out are, what concerns you most about your asthma medicines? Or how are you getting along with your asthma medication? Or for their asthma, what worries you most about your asthma today? or I know in the DVD that goes along with this, one of the questions they asked was, I sense something more is bothering you. She was just responding to sort of a nonverbal look on the mother's face. It's that she had something to say or a concern, and so it was, I sense that something more is bothering you. Is there something else here that you could tell me about? So I don't know if you all want to contribute. I'm sure you have a lot of experience with the asthma medication fears, and I don't know how you try to bring those out.
Usually, especially when it is a compliance issue, 50% of parents express the feeling that taking a medication every day is worse than taking prednisone whenever is needed. To them, everyday medication means you are sick every single day. But if they just take prednisone maybe every other month because they're having an asthma exacerbation, it's just like a cold. What's the difference? So that's how the whole education and communication again comes in the picture. And that's how we try to explain to them the dose that they take every day is microgram and how smaller of a dose of a steroid it is compared to using prednisone for 5 days or 7 days, and we just go from there.
And
but that
have
is
to
what
underline that they have that inflammation all the time. In fact, that was in the study. The study showed that patients felt like asthma was an episodic disease, that they only had it when they went into the ER. And interestingly enough, the families and patients who had less severe asthma were the ones that used the emergency room more. And the ones who had serious asthma were more careful. But maybe that's a reflection of how serious, how important.
Wow.
Are there other things anybody wants to contribute about how they promote, how they ask questions to increase the exchange of ideas and feelings or bring out those fears?
Well, there is a concept too, or strategy in motivational interviewing called asking for extremes. And I think this is another one that really can work well with teenagers, but what's the worst thing that can happen to you in the asthma attack? Or what's the worst thing that could happen to you if you don't follow your medicine? And then if you were to, what's the best thing that could happen? So you're getting them to look at the opposite ends, and that maybe you hope something comes out that you can work with, like, well, the best thing that would happen is I'd never have an exacerbation and have to go to the hospital. Great, there's your place to start the work. This is what could help you get there. So, I don't know. That's just a quickie, but it's called cueing or asking for extremes.
About the extremes. Any other ideas? Okay. So the next 3 strategies, there are 10 of these, so we've gone over 5, this is will be 7, and these 3 strategies are really aimed at preparing patients to carry out the treatment at home and to incorporate family members in decision making. And that is basically, these are looking at goal setting and individualizing your messages for the client. So, for example, tailoring the message. One of the questions that I pulled from the motivational interviewing text was to understand how taking the medicine might fit in their day. Can you think of a day that's fairly typical for you, and describe that for me? And then, or what is your usual morning routine? How could you fit the medication in your morning routine? And maybe you all have other ideas about how you start off asking how you could individualize the taking the medication in their day.
Yeah, I just have them
Those
put it
are
by
good?
their. Yeah, those are good. Put it by their toothbrush.
That's exactly what we tell the kids.
Put the meds by their toothbrush.
Because we want them to rinse their mouth after they take the inhaler, the medication. So we always tell them, just put it next to your toothbrush so you can use your inhaler and then brush your teeth and you're done.
I do that with my floaties. And then planning for decision making. This is for, adjusting medications when they have trouble or setting long-term goals. One of the questions that I thought of in that regard was to set up the conversation about making a goal is, what would you like to be able to do that your asthma stops you from doing now?
That's a great question.
And then you have something to start with for making a goal.
And that's your opportunity when you're doing this decision making too, and trying to get them to come up with their self-management plan, that you want to really seal the deal with, asking questions about importance or confidence.
Mm-hmm.
And you can always, say they tell you, I'm only at a 3, that I could do this. I'm really nervous. And okay, what would it take to get you from a 3 to a 5? And how could I help you? And then they might tell you more about what's making them afraid they won't be able to follow it. Okay, and then you hear that, whatever those reasons might be. Well, this is what I can do to help you. Let's try this, and when you come back, I'm going to see if you hit the 5. Just ways to strategize and sealing the deal, getting them to agree to do the thing, and then come back and talk to you about it.
Other ideas for starting on goal setting? And then the last two are building that self-confidence. So if you see opportunities during the visit to give them nonverbal encouragement, Carol and I talked, we'll just, give them a thumbs up or a smile or a touch, and then verbal praise. So one of the ones I thought of were, as you're going through goal setting, if they come up with these ideas that you're going to put them in the driver's seat to come up with, then you're going to say, wow, that's an excellent idea. I'm impressed. You can do this. You can do this. Other ideas or comments or strategies that you already use in this regard? So this is key point 5, that good communication and patient education can be efficiently and effectively accomplished in several standard primary care visits, and that these communication therapies don't slow you down. They've done research and they don't feel that these will slow you down. In fact, they might save you time, and because they're more effective and bring these things out and work well. And so there's evidence that shows that these work. And I've included a slide here showing that in studies with the PACE program using these, pediatricians were more confident in developing plans. And parents reported that the pediatrician tried to find out about their parents' concerns, and that they were more likely, so they felt it. They felt that the pediatrician was more likely to, and it was more likely to encourage the child to be active, was more likely to ask if the child was meeting goals. So they felt that there was better communication. And patients whose physicians participated in the PACE seminar had reduced ER visits and reduced daytime symptoms, and reduced days with decreased activity. Compared with controls, physicians who received the intervention showed increased use of written action plans, increased use of the medication, and more attention to patient fears, and no additional time for the visit.
That's a biggie.
So that's all I have. Does anyone have anything else they want to contribute, or cases?
Questions?
I have one question or comment, and maybe it's so simple that I don't see through this, and maybe it's been addressed, but how many of us have heard that their Flovent inhaler didn't help for acute illness or acute wheeze even after they've been to the specialist and seen us 10 times? why doesn't the American Lung Association and or the drug companies push for having all rescue inhalers color-coded to say red and all control asthma medications to be green? Has that been addressed?
Well, that's
and
like
would it be possible?
that's one of Kathy's crusades. Because it is confusing, and they all look different, and they're like, oh, I use my red one. Well, red is ProAir as a rescue,
Exactly.
and Symbicort as a controller. And so it's very confusing for folks. And so she does color coding with either a label around the canister or a dot, but then the dots fall off. And yeah, I don't know that there's ever going to be a good solution, but trying to put a dot on it, or really this is the one you take, or put a R or a color band on this, or a C for controller to get the patient to recognize. But my patients mix them up all the time.
So I designed this little duct tape system, red and green duct tape, and because some of the medications don't have counters, that's another issue. So then you ask the patient, one of the suggestions, you put tape on it and they do hash marks. So I just thought, well, why not use colored duct tape? So you put the red colored duct tape and wrap it around the inhaler, and you can use it for hash marks, and it also corresponds with the asthma action plan, and a green one for the controller. So I've worked on that with Dr. Harkins.
Mm-hmm.
And we brainstormed what could go wrong with that. And I learned how to tie it on so that you could take it off, because you have to be able to take it off to clean it. And so I figured out how you could tape it on so you could take it on and off when you clean it. So I can show you how I did that.
But you're right, it would make things so much simpler, but I don't think we're going to have
I don't understand why this wouldn't be a national push. I don't see any downside. And I would think it'd be something the American Lung Association would really, as asthma education goes, we shouldn't have to. I understand, and I have little stickers to put on my inhalers now too. But why should we have to do that? And is it been pushed, or is there some reason the drug companies won't do it? I don't understand. Even if the top part was red or the top part was green, they can have all their logos on the rest of it. I just don't understand it. I guess I'm a simple-minded person.
No, you're not. You're very logical. And it just has not been pushed. It's never been a big push issue. So.
But maybe you could help me with this.
Oh, you've been volunteered now.
I'd be happy to.
Great. Good. Other questions, comments?
Michael, this is Christina from Rio Rancho.
Hi.
And actually, Merck gave us some sheets of stickers that says they're color-coded, that says one's controller and one's rescue.
Yeah, she was here too, and I have those. But again, it just begs the question. But yeah, I've been trying to use those too.
Good. And I'll be out there at Rio Rancho on Monday, so I would like to see those too.
Yeah.
Okay. Well, I don't think we all said our names, but Dr. Good and Dr. Kastimsap and myself are on the line.
Great.
Oh, thank you, Dr. Is it Dr.
Good.
Gutierrez Barella?
Barella, yes.
Great. Thank you.
Thanks.
Well, reconvene in a couple weeks.
Have a good weekend.
Thank you.
Hello, this is Dolores Trujillo.
It's so familiar.
When we were talking about...
Hi, Dolores. I do have you written down as present.
Oh, thanks.
You want to interrupt?
When we were talking
Not
about
at all. Thank you.
Yeah, thank you. That was very interesting.
Now, you said she needed to send in her credentials?
Yes, if you could send those to me. Let's see. On our website is my email address. It's kwirling@salud.unm.edu. It's on our staff page.
Okay, thanks. Okay, thanks.
No problem. Thank you.